He is one of the Ilizarov purists, once again trained in the original Ilizarov methodology, and he has not deviated 1 inch or 1 word from the original master's method. And amongst our faculty, the only one gentleman who would not use even one shan screw in his constructs and is rather proud of his feat is Shibu. Welcome, Shibu.
Thank you, sir. Well, greetings to all of you from Kerala. Good evening to all my respected teachers, friends and colleagues. Greetings to you all. This particular topic that what Prakash sir told me was on upper limb. This is not for beginners to take home. This is for completion's sake. I've been told to give this topic on Ilizarov and its applications on the upper limb. So most of the cases for humerus I've used as for fresh fractures, and for completion's sake, the forearm I've be showing some non-unions and infections like that. Ilizarov method for fractures of the proximal and distal humerus. Introduction. Fractures of the proximal humerus are common and debilitating injuries. It's one of the most common osteoporotic fractures. Proximal humerus fractures account for 2 to 4% of the upper extremity fracture and 5% of all in the emergency department. There's an universal agreement that most stable fractures which can occur in elderly patients can be treated non-operatively, but controversy surrounds the more complex, displaced and multi-part fractures which usually occur in younger age group. Two conditions if you want to go for non-operative, that what I've read and what I follow is if displacement angulation is less and if the humeral shaft and the head moves as one unit, it's better to leave it and treat it conservatively. Wide range of treatment options available for these injuries with its own advantages and disadvantages. But however, for the past 10 years, we've been seeing a considerable increase in the reconstructive implants available to treat these injuries. As you all know, there are various ways to fix it: transosseous suture fixation, percutaneous spinning, intramedullary nailing, plating, which is most commonly used, and lastly, Ilizarov fixation. This photo I have taken during a period while I was in Russia. That time we didn't have digital cameras. It was a regular SLR camera. I saw these girls by the riverside just having a chat or a coffee or something. It's a fancy there to color their hair. In spite of their age, they color it in different colors. As we all know, there are different ways to bell a cat. In this way, there are different ways to color the hair. So different ways to treat a fracture. We follow the same principles and method as in Russian Ilizarov Center, Kurgan. My sincere thanks and gratitude to my teachers here in Ilizarov Center. Important aspect of Ilizarov method. As far as it's a closed method, as far as possible, we don't try to open the fracture. So while taking the X-ray, while shifting the patients, for positioning the patients, etc., we give utmost care to the broken part. Radiographic evaluation. Before the surgery, we take two views. Usually, most of the cases, it's an AP and axial, but here we take AP view, where the cassette is kept at the scapular plane and beam is facing anteriorly. And in the oblique view, the cassette is kept in the same plane, but the beam is slightly tilted 45 degrees. So you get an oblique view. We don't abduct the arm and take a lateral view, because that way we might damage further and cause severe pain to the patient. And the axial view is usually taken in the operation theater after anesthesia. There we get a better picture. Ilizarov fixation is minimally invasive technique. Distal humerus traction is if it is for treating proximal humerus fractures, we do a distal humerus wire is passed and the traction is applied. And before doing anything, a close manipulation is tried. While the traction is on, we try to reduce the fracture site as far as possible. Close manipulation is tried. And for distal humerus fractures, as there's no space on the distal humerus to pass the traction wire, we use the olecranon and pass the traction wire. This is just a picture showing a compound fracture. Here, distal humerus fraction is applied. The pin is covered with that cloth. We always use a progressive construct. This again, as I was explaining on the table this morning regarding the tibial fractures, this again, like the marker wires are kept after traction, after close reduction, marker wires are kept this way, so we know exactly where the fracture is and where the pins could be and all that. This is, we don't use a C-arm, instead we take portable X-rays. Is something similar, traction applied, and according to the site we pass these wires, multiple pins are passed and the rings are assembled in a constructive way. Some cases, a proximal humerus, a sister, non-sister, 68 years. I again appeal to you, I all know that there are different ways to fix this, and here our topic is Ilizarov fixation. Patient with the frame and X-rays, and a function and the X-rays. All this was done closed. There is another elderly man, 67 years, osteoporotic, X-rays and the frame. And his function soon after, but later it improved. Unfortunately, I did not have a photograph. Fracture dislocation. This in fact came to us after 3 weeks. 2 or 3 cases such all came late to us. Of course, open reduction was done for reducing, and because of the osteoporosis, we went for Ilizarov fixator. Another lady, 69-year-old lady, came 2 weeks later. Open reduction and Ilizarov fixation. A function and X-rays after removing. Male, 53-year-old patient. All these patients were done closed. His frame and X-ray. And his X-ray and his function. Now coming to the distal humerus fractures. Fractures of the distal humerus remain a challenging problem despite advances in techniques and implants. Distal humerus fractures account for approximately 2% of all fractures. Treatment options. Unlike the proximal humerus fractures, the most distal humerus fractures has to be treated operatively. Where back in 1937, Eastwood stated, a perfect anatomical reduction is not necessary in order to obtain good results. Bag of bone method of elderly is still followed. For elderly is still followed. Some of the cases, another 82-year-old sister, highly osteoporotic, patient with the frame, X-rays with the frame, and her functions. Another 49-year-old male patient. In such distal fractures, when it comes to pylon or when it comes to distal humerus, we always immobilize the adjacent joint. His X-rays and his X-rays after removing the frame and functions. 33-year-old male patient, an engineer by profession. Here we give olecranon traction and try to reduce it. Close reduction is attempted. Patient with the frame and X-rays. With those olive wires, we try and pull those fragments and approximate. X-rays, and after some time we remove that distal ring which immobilizes the joint, and his X-rays and function. 43-year-old female patient, X-rays after removal and a function. 24-year-old male patient, his X-rays and function. This was compound fracture, an engineering student, and his x-rays and function. On an average, the frames were removed for neck fractures after 2 months, upper third fractures after 3 months, and distal fractures 3 to 4 months. All the fractures united with pain-free extremity and fairly good range of movements. In one intra-articular, the fractures, the ROM was not satisfactory. In our experience also, as far as the shoulder joint is concerned, a good outcome does not require near anatomical reduction, as is well compensated by shoulder motions. All our patients, irrespective of the age, tolerated the frames well. Some of the complications of the 95 patients treated, 7 developed neuropraxia, which recovered after 4 to 6 weeks following surgery. One patient, there was pseudoaneurysm seen after 1 month of removal of the apparatus. 5 patients had delayed union and loose wires had to be changed during the treatment. One distal humerus fracture did not unite as the patient did not agree for reinsertion of wires. Fortunately, no pin site infections were noticed even in diabetic patients. One contradicting things that observed in our study, we also would agree that the goal of treatment for intra-articular fracture is near anatomical reduction as far as joint surface. But as I've shown, most of the cases were done close without opening, so we couldn't get a near anatomical reduction. But in spite of that, the function was satisfactorily good. And also we all know that disabling stiffness develops if the elbow is immobilized for more than 3 weeks. For all these patients, we applied the frame without opening the fracture site, for we cannot get anatomical reduction. Also, these intra-articular fractures where the elbow was immobilized for over 6 to 8 weeks, it did not cause any additional stiffness. I really do not know what the cause. One claim is that the intra-osseous pressure is reduced by these multiple pins and all these helps. That's what I read somewhere. Now, for completion's sake, I've included some forearm. This patient came to us late. Usually for distal radius with a dorsal tilt, we usually apply, my colleagues apply plates, but I use an external fixator with wire. And whereas a volar tilt, I prefer an Ilizarov fixator. This, in fact, came to us late. Patient with the frame. It's basically ligamento-taxis, or else, as so said, just go to the site and try manipulating it with periosteum or something like that. Patient with a frame and x-rays and air x-rays. Her function. This is just a case of non-union of the ulna. The pin was removed, just gave compression and it united. This infected non-union. The last X-ray shows the picture after removing the implant. After debridement, his X-rays. It united. Another infected non-union of the radius, 39-year-old female patient. Thrice they had done plating elsewhere, and this was the picture. Because infection, we had to resect so much of the radius. And always in infected cases, irrespective of where the segment is, I always wait for some time to see, as Dr. Amar said, like we wait, then later only we go for the osteotomy. And slowly started distracting that osteotomy site. Callus, distraction callus shown. A patient with the X-rays, frame on. And this is how it got united. When compared to the ever-changing conventional implants and methods, for Ilizarov method developed way back in 1951 to remain without much change on the basic ring fixator and its application from the time of its inception, proves beyond doubt that's a time-tested method. This book, old book by Asami Operative Principles, says familiarity with this method will increase the indication with time as certain advantages are realized. In this method, nature is only assisted and not hindered in any way. What Ambrose Parry, the great surgeon, said, I apply the dressing, God heals the wound. We believe that to be the reason for our patient compliance and favorable results so far. Thank you.
So now we come to the end of the theory session this Saturday. So let me start with a short synopsis. In 10 minutes, I'll just summarize what has happened since morning. Some of you might have come late, some of you might have slept off, some lectures might not have been as interesting. You might be going for tea or food. So I'll just give you a very, very short summary. I started off in the morning and talked about what exactly Ilizarov methodology is. And I said that tensioning of the wires, corticotomy and compression distraction are the three principles on which nature is assisted by Ilizarov methodology. Next, Dr. Gautam Chaudhary came and he listed all the components, and you were familiar with the components during the workshop. Terminology is more or less standard. You have got the PDF files in the DVDs you have. Go home and read them. Now besides the point, one word about the DVDs. You have all got 10 DVDs. There are totally 654 orthopedic textbooks, a lifetime's reading. So you may take many, many years to read them. So save them safely, keep them on a hard drive and use them wisely, because knowledge doesn't come so easy. The next talk in the morning was by me. I spoke about, next talk was by Dr. Arvind Verma, who actually taught you how to apply a frame, and then he animatedly taught you personally as well how to attach the rings to each other and how to attach the rings to the limb, the technical nitty-gritty. And my talk was about safe corridors, and for this we have a great help by Dr. Himanshu, who has taken the trouble of xeroxing 100 copies and sending it all the way from Saranpur, and all of you have got that. In any case, if you lose that sheet of paper, don't worry. The same thing in color chart is another PDF file which is on your DVDs. Now, any of these DVDs don't work or anything, you just have to send a message and send your address. We'll send you off the DVDs again. After that, we had a workshop in which I think everybody participated, and I had, I think everything was enough except for one drill machine which was short. Afternoon session started with Dr. Subhash Sharlia. I know it would have been terrifying. Some of his complications would have scared you. Patient getting psychiatric troubles and lack of sleep and fighting with everybody and getting illegal consent and photograph and everything. Don't get very scared. If you're using Ilizarov for an infected non-invasive tibia, you don't need such big consent forms. But if you're using it to lengthen a girl from 4 feet 10 inches to 5 feet 7 inches, obviously you need bit more than that. The 23-page consent may not be enough. And anybody who wants this consent, Dr. Shalya has agreed to send a PDF copy to me, which I'll put it on the group, so you can copy it up, make a Word file and use it. Then came Dr. Yunus's